today I'll be talking about the evaluation and management of suprascapular neuropathy. The condition was first described by Copeland and Thompson back in 1959. Although it is a relatively uncommon condition but can cause a significant amount of pain and dysfunction in patients. The nerve follows a tortuous course from the neck to the posterior shoulder, and along this path there are several points that it can get entrapped, especially in the suprascapular notch and also in the spinoglenoid notch, where the course is limited by ligamentous and bony compressions. Traction neuropathy can also occur, especially in healthy young adults, because of repetitive overhead sports and movements, and also in older patients as a result of a massive retractor rotator cuff tear. The cause of the neuropathy should be identified, as the management is dictated by the cause, where traction injuries can typically respond really well to non-surgical management, but most of the compression usually respond best to surgical decompression. Talking a little bit about the anatomy of the nerve. So the nerve has both sensory and motor functions. It provides sensory fibers to the coracoacromial ligament, acromioclavicular, and glenohumeral joint. And in 15% of the population may have a cutaneous branch supplying the sensation in the lateral arm. The chief motor function of the nerve is that it innervates the supraspinatus and infraspinatus muscle bellies. The nerve itself originates from the upper trunk of the brachial plexus, mainly C5 and C6, occasionally some branches from C4, from which it courses laterally through the posterior cervical triangle to reach the suprascapular notch. So after exiting the posterior cervical triangle, the suprascapular nerve passes through the suprascapular notch across the floor of the supraspinatus fossa and past the spinoglenoid notch. The suprascapular notch is roofed by the transverse scapular ligament, and the spinoglenoid notch is covered by the spinoglenoid ligament as shown. Both structures have the potential to compress the nerve, as mentioned before. So neuropathy can occur secondary to a variety of mechanisms that they vary depending on the local anatomy and the nature of the insult. Anything that narrows the notches, it can be fractures or cysts at the notches, or paralaboral cysts that extend more medially, and also some dynamic insults like traction and friction or kinking of the nerve due to repetitive overhead movements, especially in volleyball and basketball players. There are other causes that has been described in studies like shoulder dislocation and proximal humerus fractures, as was discussed in the study done by Delat et al. Also, iatrogenic causes for the neuropathy has been described, especially in the procedures that they need to have posterior shoulder approaches done. The picture here describes how a massive rotator cuff tear can bowstring the nerve at the scapular spine and cause neuropathy as well. Positive findings in the history from the patient is that the pain is often described as a dull, sometimes burning ache in the posterior and lateral shoulder regions, with occasional radiation to the neck or lateral arm. The pain may be worsened by arm positions involving cross-body adduction and internal rotation, and this is mainly due to tensioning of the spinoglenoid ligament during these movements. They can also have a subjective weakness during external rotation and or abduction, which is more variable and is dependent on the degree and level of the nerve compromise. If the entrapment and impingement of the nerve occurs at the spinoglenoid notch, most likely patients will have isolated infraspinatus involvement, and this may not be functionally limiting because the posterior deltoid and the teres minor muscles can often compensate. By contrast, If nerve compression happens at the suprascapular notch, this more often causes functional deficits with up to 75% loss of abduction and external rotation strength. Patients can also report a sense of instability, and this is frequently in association with labral pathology. So asking about previous labral pathologies can be important in history taking. Also asking about the patient's job and hobby can be really important, as a typical scenario is that of a chronic traction type injury in younger athletes or laborer with repetitive overhead activities. Any history of previous operation or traumatic shoulder injury can be also valuable in history taking. Important things in doing the physical examination of these patients is just like any other physical examination that we do: inspection, palpation, active and passive range of motions. And the shoulder should be inspected for atrophy of the supraspinatus and infraspinatus muscle bellies in the fossas. In case of a suprascapular nerve injury or entrapment at the level of the suprascapular notch, atrophy of both of the muscle bellies might be seen. Isolated atrophy of the infraspinatus muscle is more characteristic of pathology present in the region of the spinal glenoid notch. Palpation of the shoulder typically shows tenderness at the supraspinatus fossa when the issue is at the level of the suprascapular notch, and tenderness from 1 to 2 centimeters medial to the region of the posterior superior glenohumeral joint line in case of compression at the spinal glenoid notch. As suprascapular neuropathy is commonly seen in the setting of a rotator cuff and labral pathology, stability testing and further evaluation of rotator cuff function is necessary. In addition, an examination of the cervical spine, including palpation and specific testing of the function of C5 to T1 nerve root function, is important in differentiating suprascapular neuropathy from more proximal causes of overlapping symptoms. A complete plane radiograph series of the shoulder, including a true AP, scapular Y, and axillary views, are routinely obtained in evaluation of suspected suprascapular neuropathy cases in an effort to identify any bony sources of the potential nerve entrapment. Adding a strike and notch view can be helpful because it provides an improved view of this suprascapular notch to assess the status of its foramen. Plane radiographs also allow for the identification of glenohumeral degenerative changes or the presence of superior migration of the humeral head in the setting of chronic rotator cuff insufficiency or pathology. In cases wherein osseous etiology or suprascapular nerve injury or compression is suspected based on the plane radiographs, then a CT scan should be obtained to better characterize the common locations of nerve compression or entrapment. Other modalities like MRI can also be very helpful in assessing the soft tissues or labral pathologies. The recommended treatment for patients with suprascapular neuropathy is based on the underlying etiology of nerve dysfunction and the location of the lesions. Most patients with an overuse type of neuropathy and no focal mass compression of the nerve will benefit from non-surgical management and treatment, whereas the ones with massive retractor, rotator cuff tear, or a compressive lesion will benefit from a very early surgical treatment to avoid further nerve compression and progressive denervation. NSAIDs and physical therapy focusing on dynamic rotator cuff strengthening, activity modification, and shoulder range of movement are the first line of the non-surgical treatment. The literature on aspiration and injection for treatment of cysts impinging on the suprascapular nerve is limited to a small number of case reports. Positive outcomes have been reported on those studies, and this can be seen as an option in patients who do not wish to undergo surgery. The injection or aspiration should be performed under ultrasound guidance, and the practitioner should be comfortable imaging the shoulder and performing it. The surgical management includes open release and arthroscopic release, and the arthroscopic approach is gaining more popularity in the most recent years. Although arthroscopic release is an effective and safe technique, but the surgeon should be also familiar with the open release, which can be helpful in patients who have had previous surgeries or deformities that can limit the approach to go on with the arthroscopic means. Also, surgeon must know how to proceed with an open treatment if the arthroscopic release is inadequate or fails. Several authors have described the arthroscopic release of the suprascapular nerve, but there is no standardized technique, and this is likely a product of both the rarity of the condition and the fact that successful decompression can be accomplished through both. In summary, suprascapular neuropathy represents a commonly overlooked but treatable cause of shoulder pain and dysfunction. Given that nerve injury can be irreversible, patients who have evidence of a notable compressive lesion, which is identified in the imaging studies, should be considered for surgical treatment as soon as possible. Patients without a lesion should be first prescribed a course of non-surgical treatment for a prolonged period of time, and if this fails, they can be offered to have a surgery later. Arthroscopic approaches have become popular recently, but open release is still an option for treatment for clinicians who are more comfortable with this approach. The current literature suggests that for patients who fail non-surgical treatment and like to undergo surgery, there are generally positive outcomes for the improvement in pain, strength, and function post-op. Although this condition is relatively uncommon, but it should be included in the differential diagnosis for patients presenting with shoulder pain and dysfunction. These are some references that I used for this presentation, and thank you for your time.